So first thing we were talking that day was you must know what is the flow range for bypass flow, right? For different sizes of the patient. For neonates, it's 150 above. For infants, 100 to 150, right? And then we go with around 100, and then we pick the BSA, right? Either 100 or a flow of BSA of 2.4. And then make sure you know what is infant. Neonate is less than 28 days or 1 month, we usually call it, right? Infant is 1 month to about 6 months of age, or sometimes they call it up to 1 year of age. And then make sure you know what are the benefits of cuff, GWAF, MUF, and dialysis. Make sure you understand the concept and understand what are the benefits of each and every. Some are common benefits, right? And some are specific benefits, so make sure you are able to do that. And then make sure you know how to set up the modified ultrafiltration that we did. You should know the flow diagram of that one, right? So make sure you know that one. And then in Gravely book, there is a section on deep hypothermic circ arrest, right? And make sure in those children's, you have read that section. Mostly that section talks about if you're doing the deep hypothermic circ arrest, it's good up to 40 minutes. If you're doing with the antegrade cellular perfusion, you can go above 40 minutes, right? It's a safe to go it. If you are doing a continuous flow, a low flow, there is no need to go for 18 degrees centigrade, right? You can keep the temperature above a certain, and then you know what is the flow rate for antegrade cellular perfusion, right? And make sure you know those things, right? And deep hypothermic circ arrest is always at 18 degrees centigrade, right? And make sure you know that cyanosis is more evident in children who have a higher hematocrit. The reason is if your hemoglobin more than 3 grams is not oxygenated, cyanosis is more evident. But the fetal hemoglobin doesn't let us do that, right? Because fetal hemoglobin holds on to the oxygen, so the oxygen hemoglobin curve is shifted to the left. So make sure you understand that. That higher hematocrit, more cyanosis is recognizable. Lower the hematocrit, less recognizable in the kids, right? Yeah. And about coagulation factors in pediatric patient, right? Especially in the neonates, make sure you know which is less, which is more, right? All those things. And also heparin clearance in those kids is always higher, so means they need higher heparin than the adults. And also the tranexamic acid and the aminocaproic acid doesn't work that well in pediatric as they work in adults. And other thing, we talked about 2 things. If you are giving IV anesthetic, right? Then if I have a shunt that's right to left, that means giving IV anesthetic gonna have action sooner, right? If I'm giving inhalation anesthetic, if I have the same shunt, less blood flow is going to the lungs, I'm gonna have a late response to the inhalation anesthetic. So make sure you understand if the shunt makes a difference, blood flow either going to the lungs or directly going into the systemic circulation. And if I'm maintaining the bypass, if I have to go on bypass, I don't have to do the sugar control, right? Type control, make sure you know that. And if I have a BT shunt or any shunt, I don't have to go on a full flow until the shunts are clamped and both venous cannulas are in place. And we always measure the pressures in those kids with the left atrial line, right? Because the pulmonary artery catheter is not being put in place. Some of the complex anomalies won't let us place the pulmonary artery catheter, right? And when you have a BT shunt, right radial pressure is not a reliable thing, right? So that's from the book. And where you cannulate in hypoplastic arch depends upon if the hypoplastic part is a little small, right? I can still do the ascending cannulation, but preferable I will do the PDA, right? And so then they cool down the patient, and then they repair the hypoplastic arch, and then they come back on bypass, right? And for transfusion of great arteries, always the aorta, but high up in the aorta, right? I will do it. For interrupted arch, I will always do the PDA. So hypoplastic, I have the option, but in interrupted, I don't have the option other than the PDA. I can use the single venous cannula, I can use the double venous cannula, I can use the triple venous cannula, right? If I need to, because of the left SVCA. And I should know what are the modifiable. Hello, Austin. Hello, Bradley. We are recording, right?
You don't trust them, do you?
I would.
For what?
Huh?
Oh, he said we're recording, so I think he didn't trust what y'all were about to say.
Oh, don't say nothing bad.
Yeah.
Yeah.
You look good out here.
It's okay. All right. I was afraid to cross the border. Oh, okay, we will talk.
Yeah, we're recording. You're fine if you're on the north side, south side, go ahead.
So make sure we know the modifiable and non-modifiable factors for the neuroinjury, and how we can minimize the neuroinjury. So there are a few things, strategies we can deploy, right, where we can do that. And neuromonitoring, which are the monitors that are good in what situations. In deep hypothermic circ arrest, yes, EEG is a good monitor, but deep hypothermic circ arrest, no. Transcranial Doppler, it doesn't measure the oxygen, right? It measures the systolic and the diastolic velocities, but if my aortic cannula is blocked, right, I have a high resistance, my systolic gonna come down. If my venous is blocked, my diastolic gonna come out. But that's a good for me. If I have a transcranial Doppler, if my venous cannula is blocked somehow, if the diastolic velocity comes down, oh, I know it. It's my venous is kind of, my blood flow to the reservoir is not there because my venous is blocked, right? So, and our nears are dependent upon the oxygen, right? So make sure the nears depend upon venous oxygen, majority part, not arterial oxygen, right? So it's a combination of our capillaries, arterial and the venous, but majority is venous. And they are difference between the oxyhemoglobin and the deoxyhemoglobin, right? What is the difference between those two mechanisms? We talked about systolic velocity and diastolic velocity of the transcranial Doppler, and the transcranial Doppler doesn't differentiate between gaseous and solid emboli. Okay, when it comes to measuring the emboli. Nears, oxyhemoglobin, deoxyhemoglobin, that's the mechanism of action in the venous blood, majority in the venous blood, right? And transcranial Doppler is mainly in the middle cerebral artery, right? That's where we measure it. And there are some enzymes that make the myocardium more tolerant to the ischemia, and there are some enzymes that make the myocardium more prone to the reperfusion injury. How are you? More prone to the reperfusion injury. So make sure immature myocardium, you know that, right? And make sure you know there are ischemic factors that can injure the myocardium, and there are non-ischemic factors. So make sure you know those non-ischemic factors as well. When it comes to a cardioplegia, right? Make sure you know which cardioplegia have a which mechanism of action. Intracellular has a different mechanism of action when it comes to where the different types of cardioplegia do the arrest on the axon potential, zero phase, 1, 2, 3, 4, right? So one is they capture at the diastolic, and one is they capture at the depolarized diastolic phase, right? So always the extracellular one capture at the depolarized diastolic, but the intracellular capture at the resting, almost the resting at the diastolic phase. So make sure you know that. And make sure you know why at the mannitol for a couple reasons, right? And the blood is like a buffer. It's a sodium bicarb. There is no need for the sodium bicarb because blood is the biggest buffer in the body you can ever find. What is the buffer in the body? Blood. What is in the blood? That's the buffer. It's the hemoglobin. It's the proteins. Those are the buffers, right? The protein is the biggest buffer, and the hemoglobin is the another second biggest buffer in the body, right? How is the buffer? It can bond to oxygen. It can bond to carbon dioxide. It's a buffering, right? Acidotic end. Why we give the magnesium sulfate in the cardioplegia? Make sure it does something to the calcium. It does something to the sodium as well at different stages. Custodial, there is a tryptophan, there is a histidine, there is a ketoglutarate, right? What are those three ingredients and what is the purpose of those one, right? One is the ATP, one is the membrane stabilizer, and one is the buffer. So make sure which one is which. And which procedure you can insert the pulmonary artery catheter, which procedure you can't insert the pulmonary artery catheter, or even it's not a reliable. Mustard procedure, it's not reliable, right? Left heart syndrome, I have it. Where it gonna measure? There is no left heart, right? So there is not reliable. Glenn is not reliable, right? And cannulation venous, we already talked about. We can have a single cannula, we can have a double cannula, we can have a triple cannula, but it's not common to do a single cannula in pediatric patient. It's always a Y cable. If you are repairing a subaortic stenosis, you know it is subaortic stenosis. You never know. I may have to go through the septum to do that, right? So that's why I always do the venous double cannulation rather than a single. Because subaortic stenosis, I can do with a single cannula, right? But no, they try to do the venous because they may have to do something else. And then redoing the cannula, say they do two cannulas, right? Cannula placement, aortic cannula, we already talked about the hypoplastic left heart syndrome where we cannulate, right, in the PDA. And interrupted arch we already talked about. Transmission arteries we already talked about where we cannulate, right? And alpha stat, PS stat, I think probably by now I don't have to explain you which one is temperature captured, which one is non-temperature, where we give the CO2, where we don't give the CO2, where we decrease the sweep, where we don't decrease the sweep, right? How it does all those things. Which one is alkalotic, which one is acidotic, and when we do it, temperature coming down or going up. So which phase? When we are going down, pH stat, then switch to alpha stat, few minutes before the hypothermic sac rest, and then rewarm at alpha stat, right? Not pH stat. Any factor deficiencies, which one is less, which one is normal in pediatric population or neonatal, especially the neonatal population up to 6 months of age, right? Cyanosis we already talked about. Immature and the mature myocardium, which one is tolerant, which one is reperfusion injury, right? More prone to reperfusion injury, more tolerant to ischemia, right? When it comes to normal immature myocardium, it is more tolerant to ischemia. But if I'm suffering from a congenital heart disease, my myocardium is already stressed myocardium, we call it. That is also prone to ischemia, okay? So make sure you know the difference. And cardioplegia flow rates, induction in the maintenance, make sure you know it's 10 and 20, right? Up to 30. And Dalnido cardioplegia, what are the ingredients in it? What is the ingredients in HTK? What is the ingredients in St. Thomas, right? St. Thomas, mainly magnesium and potassium. Magnesium is additive, potassium is the main ingredient, right? If I have a lidocaine in it, that's additive. So make sure you know which one is additive, which one is. how the ischemia reperfusion injury. There is a section on ischemia and reperfusion injury. Make sure you read that, right? If you have to write the mechanism of reperfusion injury. You know, there are three mechanisms that can happen in the reperfusion injury. One of them is a calcium, one of them is an endothelial injury. So make sure you, and the other one is a nitric oxide impairment, right? So make sure you know about nitric oxide in endothelial injury and also the prostacyclin. So there are two things, those are important in endothelial injury. We talked about mannitol, we talked about which is intracellular and extracellular cardioplasia, so make sure you really know the difference between intracellular and extracellular when it comes to ingredient, when it comes to mechanism of action, and what pressures we can deliver the cardioplasia in neonatal population, and what it will do if we don't do that. If we have a high pressure, it will cause the edema, it will cause the endothelial injury, especially in that immature myocardium. Which cardioplasia solution you can use as crystalloid cardioplasia. There are some you can use for blood, some are crystalloid, and some you can use for just either blood or also crystalloid, right? Most of the cardioplasia, to be technically, you can use as a crystalloid cardioplasia. Whether it's a HTK, whether it's a custodial, whether it's a Del Nido, whether it's a St. Thomas, any cardioplasia can be used as a crystalloid cardioplasia as long as you have a concentration of potassium that you need to deliver, right? 20 to 30 milliculars of per liter, right? Sometimes they give the nitroglycerin before taking the cross clamp off. Make sure what the nitroglycerin does. There are 3-4 functions of the nitroglycerin, right? What it does, so make sure you know that, what it does. It's a muscle relaxant, it does not let the platelets and the neutrophil to adhere to the endothelial cells, right? And it's a donor. It's not a precursor for the nitric oxide, it's a donor, it donates, right? Yeah. Apolipoprotein, we talked about this one. It helps in the cholesterol metabolism, so make sure you know everything about lipoprotein, right? So neuromonitoring devices, we already talked about which one are not, right? BIS is a neuromonitoring device. EEG is a neuromonitoring device. SNEERS is a neuromonitoring device. Transcranial Doppler is a neuromonitoring device, right? And when you're on bypass, if you have to prevent the brain from going bad, right, injured, right, what you have to be careful, right? You have to avoid hypotension, acidosis, all those things. What are the strategies to avoid? High hematocrit, hypoxemia, avoid, right? Don't control the glucose, so I can do that. Mechanism of action for the NEERS, make sure you know if there is a 20% drop, it is really bad. Then the baseline. If the baseline was 50, right? If had dropped to 40, it is bad, right? Below 40 is always bad, right? Regardless of. BIS is only collects from a single channel. It's not a multi-channel device. It's a single channel device that collects the EEG from the brain but presents as a simple number. Rather than nobody knows how to interpret the EEG, but they know how to read the BIS. So BIS is just a simple form of EEG, okay? But it's not reliable when it comes to deep hypothermic circ arrest, because deep hypothermic circ arrest, there is no EEG, right? And same thing is about transcranial Doppler, right? And biomarkers of heart failure. One is the BNP, one is the ANP. But ANP is not that reliable. If I have to pick one from both, I will pick BNP. But if I have a multi-answer choice, I will pick both, because both are heart failure. But the BNP is more indicator of the heart failure. And the lactic acid, no, because the lactic acid can form for any other reasons too. It's not just the heart failure, right? In CHF, lactic acid can happen, but it's not the marker for the heart failure. And transcranial Doppler, it measures the flow through the middle cerebral artery, not the anterior and the posterior, right here. Why the bridge is important in ECMO. Make sure you know why we have a bridge, right? Especially in VB ECMO or BA ECMO. Do I need in VB ECMO or not, right? So make sure you know. And then any complications, hello Hannah. Any complications of the ECMO that can happen, bleeding, right, coagulation, all those things can happen with the pediatric. And then we are recording, so you should be able to watch it. No worries. Should we turn the sweep off and on kind of thing in VA ECMO or VB ECMO? So make sure you know how we do the weaning process for the VB ECMO and the VA ECMO, right? Where we drop the flow, where we drop the sweep, right? Where it's important, where we have to keep the bridge open, where we don't have to keep the bridge open. In VB ECMO, if I don't have the bridge, I don't care, right? Because I'm not dropping the flow, I'm just turning the gas off, right? I can drop the flow, but I don't have to really drop below 500, right? So, and there are some temporary LVADs, there are some permanent LVADs. Make sure you know which one is temporary, which one is permanent, right? Yeah, Jack was asking me, I have a hard time grasping. I want to see the LVADs, right? To me, I wish we have in the lab. We can always show you, but we don't have in the lab, right? Yeah. I can bring from Canada, but it's not easy to bring. Umbrella is a short term because it's maximum 10-15 days we can keep it, right here. PA ECMO is a short term. Tandem heart is a short term. A heart rate 3 is a long term. And heart wear, we used to have a long term as well, right here. And where we keep the inflow and the outflow cannulas for the LVADs, whether it's a permanent, whether it's a temporary, right? Make sure the inflow is the one that takes the blood from the LV to the LVAD. And the outflow is the one that takes the blood out into the aorta. Okay, so make sure, don't confuse. There's gonna be certainly a question in a medical board exam on this one. They don't go further than that one. And make sure Jesse was explaining right today, if there is a pre-membrane pressure rise or post-membrane pressure rise in ECMO, what it indicates, right? Is it a oxygenator failure or it's something is wrong with the patient? Intermax score and the New York Heart Association, right? Classification of heart failure, make sure you know, right? Intermax 1 is considered bad and New York 4 is considered bad. So make sure don't confuse in between that one. When we put the LVAD, we put in Intermax 3, 4. If it's a 1 or 2, it's too late, right here. And probably you guys know the North-South syndrome in ECMO, so make sure you know where it comes. Mainly it's a femoral cannulation, it's more evident in femoral cannulation, right? Especially in BA ECMO, right? BB ECMO, you don't have it. Or if the heart is ejecting, you're gonna have that one, right? Mainly. If the heart is not ejecting, you may not have it even with the femoral cannulation. When you have a neck cannulation in pediatric patient, that's the difference. You don't have that one. Even though it's a peripheral cannulation, but neck cannulation directly delivers the blood into the aortic arch, so you don't have that. How we measure the anticoagulation on ECMO? ACT is yes. PTT, you can do it, but not without ACT. You can't just rely on the PTT, right? If you are giving low molecular weight heparin, yes, you can rely on the PTT only, right? And the anti-10A. You can do ACT, PTT, anti-10A both, but ACT is also important, right? So don't miss the ACT. When it comes to infection, how to avoid the infection, there is a paragraph on infection on ECMO. Make sure you read that paragraph, right? how many times you scrub the pores or anything when you change, right? There is a specific protocol in the nursing. I think Hannah can tell you, whoever the nurse is, there is a specific protocol to do that. To make sure you know that protocol, right? Not just one day. That yeah. So, and then there are, if I have adult patient coming in, Jesse was talking about this one, what I can expect in those patients, what are the symptoms, right? What I'm gonna have it, right? And pulmonary hypertension, I'm gonna have it, cyanosis, I'm gonna have it, right? I may have a heart valve, those are not working now because they are regurgitating back because there is a lot of pressure in the ventricle. I may have a myocardium that's stressed as well, right? And then if I have a redo patient or a redo patient, adult congenital heart surgery, already few procedures are done, right? It's coming to me, how as a perfusionist I prepare. I prepare for peripheral cannulation, how the surgeon prepare. They have a special saw, right? Oscillating saw. So make sure you know how to prepare for, I have to prepare the cell saver, right? So I may have to go urgently on pump. So make sure your heparin is ready. So make sure you know how to prepare for the redo surgery. If I am doing a deep hypothermic circ arrest where I do the monitoring, I may need a femoral cannulation as well, right? So if I do that. And if I have a person with ASD, mainly they're gonna have atrial fibrillation, right? If I have a person with a BSD, they're gonna have a ventricular fibrillation. Trology gonna have a ventricular fibrillation, right? So make sure adult patient coming to you, what the lesion is, what the probably symptoms I have it, right? And if I have to give the treatment for the ventricular fibrillation, is the ICD, right? If I'm giving the atrial fibrillation treatment, I'm going to ablate it, right? So those are the procedures. So ablation is not for the ventricular fibrillation. So make sure you understand those two things, right? And if I have adult patient coming to me with the ASD or right or any other device, if they already developed the pulmonary hypertension, there is no fun of repairing those lesions. Make sure you do not repair those lesions if the pulmonary hypertension is gone worse. Only repair if they have a cyanosis, only repair if they have some sort of fibrillation, heart arrhythmias going on, right? Only repair if the right ventricular is failing, right? So only repair up to that extent. And if I have a patient coming with a master procedure, I know patient gonna have atrial arrhythmias, right? Yeah, patient gonna be anticoagulated already, right? So make sure you know I have to give the FFP on pump when I come off bypass, right? And death spiral we talked about. Make sure you know how the death spiral can happen from right to left, left to right. It can happen from both sides, right? Make sure you understand the step-by-step process, how it can happen, right? Right side failure can get to under perfusion of the coronaries, that the left side gonna die, right? Because of the deoxygenation. And which of the congenital anomalies can be completely missed in pediatric patient that can lead to go into the adult life, right? So make sure you know those anomalies. And with that one, that's it. To me, honestly, if you can prepare around these topics, you already covered 70 topics. Your knowledge is already more than what you had, right? So that's it. Okay. So there is always an improvement. Okay. Any questions? And those are your questions, literally.
Did you mention the one with which CHDs lead to myocardial injury, both ischemic and non-ischemic?
Yeah.
Where's the best place to find that information?
Ischemic and non-ischemic, say again.
Which CHDs and their surgeries lead to myocardial.
It is in the gravity,
Thank you.
non-ischemic. If you are cutting the ventricle, you are doing the non-ischemic.
Gravity, okay.
If I'm retracting the ventricle, you are doing the non-ischemic, right? So all those things are non-ischemic. If I'm putting the ice on the myocardium, to be honest, I'm causing an injury to the myocardium, right? You know, some surgeon, they put the ice on the, if it's sitting in the ice for too long, it is an injury. They stopped it. What they used to do it when they will bring the donor heart, they will put it on the ice. They stopped it doing it. Right failure was happening a lot more because it's a paper thin. Injury will happen from the cold more to the right heart than the left heart. So yes, those are non-ischemic causes. And there is a list of causes in the gravity. Any other questions? Do we need to do anything, clarification? Otherwise, we are done before 2 o'clock. David is on now until 7. Can I come and sit in the class?
Yeah.
Yeah. And if he's taking too long, oh, I'm recording.
No,
Oh,
we
well.
let me.
Speed it up.